And now I have the great pleasure to welcome you today to WIPO. My name is Amy Dietrich. I am the director of WIPO's Global Challenges Division. And it is really a great pleasure to see such a robust turnout and such interest in the MPP study on voluntary licensing, right for health and smart for business. This was funded by the Government of Canada and WIPO. And as we're here under WIPO's roof, it goes without saying, but I'll say it anyway, that IP plays a crucial role in the innovation of medicines and other health products, and that IP at its core is a business tool that provides incentives to innovate. And in the health space, that innovation is often life-changing and life-saving. IP also provides a framework for cooperation among trusted partners through the licensing of IP rights and know-how. Voluntary licensing is one of many successful options for expanding access to medicines. MPP has developed their own voluntary licensing model with stunning success, signing agreements with 22 patent holders and 57 generic manufacturers over their 12 years, which has led to nearly 35 billion doses of treatment supplied in LMICs, saving health systems a total of $1.5 billion, a figure that is projected to more than double by the end of this decade. As the global disease burden shifts from communicable diseases to non-communicable diseases, such as cancer, cardiovascular disease, diabetes, and respiratory diseases, NCDs are killing 41 million people a year, which accounts for 74% of the global death burden. Voluntary licensing models will become increasingly important for governments and populations across the planet, which is why the timing of this study on the value of voluntary licensing and the commercial benefits it can bring for originator companies is so important. The study also provides solid evidence grounded in economic data that voluntary licensing can bridge health disparities, including with South-to-South licensing deals, especially in low and middle income countries. By highlighting the importance of integrating voluntary licensing with robust healthcare infrastructure, strong regulatory frameworks, and international cooperation, this research shows that voluntary licensing makes good business and economic sense while promoting access. In a broad sense, the study is a call to action that partnerships and trust remain the cornerstones of expanding voluntary licensing agreements and increasing access to life-saving and life-changing medicines, regardless of where a patient lives. So let's work together to leverage voluntary licensing as a positive and effective strategy to expand access to new markets and medicines. And with that, I hand over to Anthony Taubman from the WTO, who will provide us with brief introductory remarks. Tony, the floor is yours.
Thank you very much indeed, Amy, and I'd like to thank very warmly our friends and colleagues in WIPO and the Government of Canada for their support for this project, but especially the wonderful team in MPP that have put together this fantastic report. Amy's set out the context for this report superbly, and my modest role is to provide some comments on how I see the significance of this report. And I'm sure, like many of us working in Geneva, I often find myself posing the question: does everything really have to be zero-sum? We seem to operate in an environment when a negotiating advance in one direction or an acknowledgement of legitimate interests in one area is instinctively assumed to mean a loss in the other direction, a dismissing of other legitimate concerns. It doesn't have to be this way. In the field of IP, we are reminded, as the WTO TRIPS agreement passes its 30th anniversary, from Article 7, we know that the intellectual property system should operate to the mutual advantage of producers and users of technological knowledge, conducive to a balance of rights and obligations. But this understanding hasn't always been evident in the long-standing debate over IP and access to medicines. Even that idea of balance that we commonly use in identifying an appropriate reconciliation of public and private interests is in a way implicitly zero-sum. If I add to the innovation side of the balance, I need to equalize that with an equal counterbalance on the access side. Worse, it can become a kind of exclusive tribal identity. Are you an innovation person or an access person? Fortunately, this zero-sum arithmetic is empirically false and empirically falsifiable. The significance of this report. Indeed, overcoming this zero-sum instinct and moving towards a more integrated and holistic conception of how innovation and access function together has been at the very heart of the trilateral cooperation program between the WHO, WIPO and the WTO since its very inception. The tragic experience of the COVID-19 pandemic also underscored the essential need for responsive, health-centered innovation and equally for effective and timely equity in access to the fruits of that innovation. It was also a reminder about the fundamental, practical, positive-sum truth enshrined in the WTO Constitution. The achievement of any state in the promotion of public and protection of health is of value to all. More succinctly, as we often heard at the height of the pandemic, we are all in this together. Especially at a time of global health crisis, zero-sum is not only not the right answer, it doesn't even get the basic question right. One prevalent zero-sum trade-off that we can encounter in discourse in the public policy space is the idea of a sharp divide between legitimate commercial incentives for innovators, on the one hand, respecting the risks and costs of drug development, and on the other hand, the compelling need for equitable access and assurance that wealth or geographical location is not a determinant of whether you benefit from this necessary innovation, recognizing that access to essential medicines is a component of the human right to health. Are you a profit-centered person or a patient-centered person? I've often heard this crude dichotomy expressed in such blunt terms. Fortunately, and indeed fortunately for us all, this is a distorted and misleading picture. It is the light of practical experience and not of mere aspiration that illuminates the true picture. We cannot hope for a steady stream of new and adapted medicines without appropriate returns for the private sector, originators and generic producers alike. And yet responding to and overcoming global inequities in access does not and cannot realistically depend entirely on charitable donations and non-commercial avenues for production and distribution of medicines. Commercial viability and sustainability need not and should not be at odds with sustainable efforts to overcome glaring inequities in global access. This is why the study being launched today is timely and indeed essential reading for those working in the public health policy space. It is a profoundly practical study, rooted in the real-world experience of the MPP and a practical understanding of the realities of the commercial world, while at the same time keeping a clear eye on the imperatives of global health equity. The evidence that it draws together demonstrates convincingly that there is rich common ground to cultivate, and that for originators of new medicines, it is not a stark choice between commercial returns and charity. As Charles Gores Forward puts it, non-exclusive public health licensing goes beyond philanthropy and represents a sustainable way to increase access while yielding commercial returns. We have seen in the wake of the pandemic a welcome increase in interest among policymakers, indeed among WTO members in the TRIPS Council, in understanding how voluntary licensing for public health outcomes actually works in practice, and how it can be encouraged and expanded with benefits for global health, including through greater geographical distribution of production capacity. Part of the discussion concerns what incentives and other forms of encouragement are effective in promoting such licensing. This study and the MPP experience generally demonstrates that those incentives include significant commercial returns, along with other benefits such as non-diversion and talent retention. I therefore warmly welcome the study and the rich conversations pragmatic analysis, and above all, rethinking of established ways of working that I'm sure it will engender. And thank you very much for the opportunity to comment.
Thank you so much, Tony. If you can just switch off the microphone. I can think of no one more eloquent to open us up. And now I hand over to Sandra Noble of MPP, who will walk us through the study's main findings.
Thank you, Amy. I really have to thank Amy and Tony because I think we could go straight to the panel discussions. The report has been so perfectly described. So thank you very much for the considerations. Maybe I know we all have an overdose of slides, but I guess that talking to data without slides would have been a bit complicated. So apologies, we have to go again and you have to go with me through this journey. I promise it will be not a long one, so maybe a 10-15 minutes one, just to guide you through the main findings. I think you all noticed the studies outside. We will as well, I think, in housekeeping as well, sending the report to all the participants via email after this, the ones who registered. So we'll have access to the report. So I start by saying what was already said. So this study was mandated by the Medicines Patent Pool, but was commissioned to the Boston Consulting Group, who is with us in this room and whom we worked closely and friendly to get into these results. As mentioned by Amy, we only can thank the generosity of WIPO and of Canada government for having supported this, because without them, we wouldn't be here today. And of course, the guidance and insightful feedback offered by the members of the advisory board has been instrumental in pressure testing and refining the structure, content, and the language of this report. The advisory board gathered Bill and Melinda Gates Foundation, the Global Fund, the IFPMA, International Federation of Pharmaceutical Manufacturers and Associations, the JPMA, representing, and he will be here online, Japan Pharmaceutical Manufacturers Associations, and WIPO. The views expressed in this report are those of the authors and not of the funders and advisory board members. I would like to be very clear in this point. Just as well, to leave us with all the details of the analysis, there's 2 or 3 things I would like to mention. The analysis, qualitative and quantitative, was run by only based on facts. So there's no modeling behind this study. There's no extrapolation. There's no anything. So it's just data-based, so fact collection. We did it in 22 low middle income countries and upper middle income countries. We might have seen why 22, there's 140 and so. So just because this where the robustness of the data was enough good to have some data that could be of interest here. So to not dilute any results, it's where we find them. So we have I might be willing to get the slides again. We might, you have the list of the countries down. The data is MPP based and IQVIA based, as well as some interviews were run with several stakeholders to get into these figures. For the ones, I think maybe 80% of you know who MPP, how do we work, what do we do, but maybe some need some explanation before we get into this voluntary licensing or non-exclusive public health-oriented licensing. So what does MPP? MPP does negotiate public health-oriented driven licenses with patent holders. When we say, do any product in the world fits in the MPP model? No. So we negotiate these products for the prioritized list of products, which is a public list that and an exercise that we do in a continuous way, and this list is being upgraded every time we have updated anytime we have a new candidate. So we discuss with the patent holders, we try to understand whether an agreement, a partnership, non-exclusive, as I said, license agreement could be done. And then what we do is through a very thorough process of selection, expression of interests, with a blinded process, with the appropriate mechanisms in place, we select the generic manufacturers that will produce quality assured versions of the products we've been in licensed. So they receive a sub-license from the MPP, and they will be then for a specific territory in a specific geography with and I want to say here, every agreement is bespoke. So it's like any license agreement we do in the pharmaceutical industry. There's a negotiation, and every clause is negotiated. There's no templates here, which is very relevant. And then, of course, and I think the cause that brings all to this room is making people living in low-income countries having access to these quality-assured medicines in due and short time. So this is the aim of the model and how we do it. So when done in right conditions, because there's risks associated to voluntary licensing, we have to tackle them. We have to be and be cautious when applying it. But when done, and I say when done it with MPP, with the right conditions and the right partner, this can lead really to increase the patient reach. So people in need will have access to medicines, contribute to what I think brings us to Geneva this week, which is reducing global health inequities. And of course, as mentioned by the two introductions, represented an economic viable, and when I say economic viable, that is a non-damaging commercial business model to launch and make the innovation accessible to this world. So now I go a bit faster. So why are we here? We have the generic industry. They know the model. They're very happy, and each time we open a new OI, there's hundreds of applications. So people, they know, they are interested, they understand the benefits of the voluntary licensing. In terms of patients, when we put patients here, it's the overall global health community. I think as well, there's an understanding and a global understanding what the benefits of doing such are. When we talk to patent holders, and this is my personal experience after being 25 years in the industry side, so I have both sides, and I can let you know that there's a series of concerns that are maybe due to us not being able to explain the value behind the voluntary licensing than just saying there's kudos, there's PR, there's corporate social responsibility, there's philanthropy. No, this is another thing, and there's something that we had to explore and understand how to incorporate in the business as usually launch strategies. So when you have a global launch strategy, we have to try to understand how can we cover for the planet, and cover for the planet maybe at some point having to consider voluntary licensing as an access mechanism in certain geographies. So that's, of course, as I say, there's the direct and indirect benefits, and that's why we understand that we needed this report, because equitable access, a widely acceptable, goal is still very far from being achieved. We understand as well by talking to them and by all the conversations that fortunately we're able to have biopharmaceutical companies who hold one of the keys of advancing the global health equity. So can we start talking and seeing what kind of partnerships can we establish together to making this happen? Non-exclusive public health licensing has been hugely underutilized in the infectious disease space. And when we talk about namely the HIV, I think everyone knows about it, and maybe 90% or more, I think more of the patients on treatment are on enabled MPP drug or drug regimen. So we aim at demonstrating that voluntary licensing goes beyond philanthropy, can be business as usual, as I said, can generate commercial benefits with no cost for the companies, and this is maybe where we have to put emphasis. There's no damage of the P&L, of the commercial benefits, and with very little risk. That there's risk, but well mitigated becomes very little. So we've identified what we call, and the drivers, business drivers, and have identified 8. So before, in the beginning, it was 11, and maybe you've been in some presentations and I've been presenting it as 11, but the data was not robust enough for us to support the other 3. We hope that by starting utilizing it more often, we have enough data to then have more drivers and come back into this room with more data to show you. So yes, voluntary licensing can be both right for health and smart for business. It's time to change perceptions. And I'm personally, and I think at MPP, in the dialogues we have in the industry, understand that it's a question of perception more than a question of huge and or really clear barriers that can't be removed. And some of these perceptions is the ones we would like to tackle. So the 8 business drivers are identified. Just cautious of time. We have we have three buckets, and maybe here we go with the bucket. So we have the core benefits. What is the direct benefits for the companies who will decide to enter in a non-exclusive public health oriented partnership with MPP or differently? We have the avoided costs, so the costs that they're not incurred with because they were avoided, because in this case, if you go with MPP bears them, and we have secondary benefits. So in the first bucket, we have the additional revenues, the more patient reach, and you'll see the numbers, the market shaping capabilities, unlock new patient segments. So this is all core benefits, the things that are tangible, very easy to measure, and they're there. If we go to avoided costs, this is also very measurable, because everything that is done by us in terms of MPP will be saved to the company. And this can be putting in place an infrastructure, building knowledge internally in terms of regulatory or technical or others. So this is a cost that is avoided by the partner who work with us. In terms of secondary benefits, it was a beautiful surprise. So there's HR costs avoided that I will explain you later on the slide. So one by one, I won't go into the right slide of this detail. I just have this, the right side of this slide. Just would like to mention to you that each, and we'll be having access to the presentation, the detail of each one of these sentences that can be sometimes very dry is in the report, the methodology is there, and the page where you can find it is mentioned here. So if some of the drivers talk to you more than others, you can go explore, talk to us, try to understand with anyone around here in the panel why, and we'll be able to guide you through. So usually people say upper and low middle income countries do not represent an interesting market for biopharma companies. There's no money there. There's the capacity of buying or affordability is very low. When you go and dig into the data, we see that in the countries we've explored, the market represent between 6 and 28% of the sales are done by non-originator. So there's a market. And if we tap into this market, there's a potential to generate revenue. So additional revenues for implementing royalties in upper middle income countries in one of the examples we've studied could range from 2 to 17%. So based, of course, on some assumptions that I invite you to dig in. But there's an additional revenue that can be made. So as I said, not only it doesn't damage, but it can, at the end, increase revenues. And this is why brings it here, is that by doing this, we reach 4 times more patients. And what we are here about is to talking how can we reach more patients. So this opportunity of partnering in these countries at the right time with the right molecule in the right way allows us to reach 4 times more patients. So this is relevant because it's really the huge number. In terms of market shaping, I think there's no talk in Geneva this week where we don't talk about capacity building, infrastructure, diagnosis, all this that is missing. So by going not directly, by going with a non-originator product, these activities have to start. We have to kick off all this. So you have to have budget lines on the governments associated to the therapeutic area in case we have to have diagnostics in place. You have to have companion drugs in place. So everything in terms of market shaping has to start. And we've seen that the second manufacturer, so the one who comes after the first sale, grew the sales 4 times quicker than the first, which is almost counterintuitive because the conditions are there. The ecosystem is ready to receive this drug. There's new patient segments, so there's no cannibalization. The non-originator sales are not taking patients out of the regimen of the originator if they were any there. So this is a new people, and this new people is the 4 times new people, is the people that are in need and will never, ever maybe have access to this product. So this is the ones we want to touch with our drugs and make them having access to when we talk about voluntary licensing. And of course, there's a structure behind, you all know about MPP. We have in-house internalized most of the expertise needed to do it. So from, of course, the in licensing policy advocacy, all the efforts to get a license, but as well, everything that needs to manage a license, which is really costly in terms of time and resources. We have a regulatory team, tech transfer team, all the support that a non-originator company might need to implement this in terms of and successfully. And it can save 2 to 8 million in terms of I think I put one slide already up. Yeah, and so I was actually talking about this one, which is the cost saved because MPP does the work. And here is something that I know is very, very high on the agenda of the concerns the originator companies have is product diversion. And I would be here for hours trying to make and put the evidence on the table how we can avoid product diversion using a mechanism as ours. And this also avoids costs from 2 to 8 million. And this one was the one that I really enjoyed because it shows that the world is a beautiful place to be in. So companies who engaged in voluntary licensing showed a direct connection with health equity is a must-have for recruiting and retaining top talents. And we've understood that people that are in these companies tend to either join or stay there longer because they understand there's a health equity commitment in these companies, which is a beautiful thing, more than the 70 or 7 or 10 million that one could save that are not negligible, of course. So this slide will be on is the summary of what I've just mentioned. Are there risks? Is this just a just go? And there's nothing associated to voluntary licensing that can go wrong? No, there's lots of things that can go wrong. We try to understand from the beginning what can go wrong and prevent in our bilateral discussions before putting the agreement and signing it in, as I say, bespoke way, everything that could be a risk and try to tackle it. But anyway, there's a risk, as I said, of the quality of the drugs that will be supplied into these markets. They are not second-class drugs. They are exactly the same quality assured products that will be distributed in these markets. So this is a risk that we prevent in terms of quality and second-class citizens of drugs being distributed. There's, of course, the product diversion mitigation I've mentioned to you, and as well the reference pricing. So conclusions, 2 minutes, not that bad. I think the conclusions were put on the table in a much more beautiful way that I can do by both the introductions of Amy and Tony, which I thank you again. There's indeed, there's some financial benefits, or at least there's not the voluntary licensing or non-exclusive public health-oriented licensing can definitely not damage commercially the companies, with maybe, if at all, something contribute commercially or giving some benefits. But I think more than this is how many more people can engage by not destroying any of the commercial interests of the company, how many more people can be reached by engaging in voluntary licensing, not damaging any revenues. So I think my conclusion is that okay, one of these drivers alone can be not impactful. All combined, we can see that maybe it's worth exploring the voluntary licensing mechanism to meet the ESG commitments, to generate goodwill, and maybe, who knows, if VL becomes mainstream, the dream of universal health coverage would become attainable. The benefits presented here can be compounded as more and more biopharmaceuticals engage in voluntary licensing. The data we have is the data we have, and there's not 1 million agreements to be explored and dig in. Joining a movement that pushes forward equitable access to health it should be recognized, and I think it's our mission as well, that alone, MPP is not one solution fits all. We'll put the universal health coverage on the table. We have to work all together, and all together means partnerships, not only voluntary licensing, but everything that I think, and then Kerry will talk more about it in the debate, will make all the ecosystem works, and not only three parties of the equation putting a piece of paper together. Many thanks.
Wonderful. Thank you, Sandra. And now I'm excited to hand over to Megmala and Siddhartha, because we have a fantastic panel of the exact partners that we're all going to need to work with to make this a reality. So Megmala and Siddhartha, over to you.
Thanks, Amy, and thanks, Sandra, for that presentation. Thanks, Tony, for the welcome remarks. That was really amazing to hear. And we have, as Amy said, we have a wonderful panel with us, a very good example of the partnership that Sandra just alluded to. Quick introduction, we have James Anderson, the Director General of Global Health from IFPMA. We have Dr. Susanna, the Secretary General of IGBA. We have Lizzie Wilson next to her, the Senior IP Attaché from the UK Mission to the UN and WTO. We have Mr. Marumo, the Deputy Permanent Representative, South African Mission to WTO. And then we have Dr. Carrie Adams in the room, who's the Chief Executive Officer of UICC. And joining us online is also Mr. Takanori Sato, who is the Chair of Global Health Subcommittee from JPMA. So thanks so much for joining us. And after having read the report, we have a common question to all the panelists, and that is, after having read the report, which driver is most appealed to you, and which is your favorite driver in a way? And we'll start with you, James.
Thank you very much. It's a real pleasure to be here and to be part of this discussion. I want to start just by recognizing a number of colleagues, but also a number of our member companies. I'm from the IFPMA, which is the Global Pharmaceutical Trade Association. And I've seen at least 6 of our member companies here in this room, companies from the US, from Europe, from Japan, very big ones, and more medium-sized ones. And the point is that is twofold, actually, really picking up on a couple of the points you made, Anthony. First of all, those companies and us as the IPMA don't accept that you can only have innovation or access. Fully agree with how you said it. We absolutely are committed to you need both, right? So that's, and I think the representation here is one demonstration of that, of many. But the second one is that each company will have a different approach to how to do that. And in fact, even within a company, each product also requires a different approach. And so, and there are a number of different approaches that are used, and they've all been seen, I would say, to work, more or less well. Frankly, there's no simple way to ensure access to all the patients that need any product all around the world. From where we look at it in terms of this report, licensing certainly has demonstrated very well that it can play an important role in certain diseases. In COVID, over 450 collaborations of different sorts, many of which involved tech transfer, were done. And yet we know that still in COVID, products didn't get to everyone around the world as fast as everyone would want. So it's not easy. Licensing is one part of the chain, but the whole rest of the chain needs to be joined up there. So in terms of the question, I think that it's a combination of the data that shows that the success of the availability of the success of actually increasing availability. That's clearly the driver. That is why companies work on the range of access programs they do, including licensing. but it is also the avoidance of the risks. And I think that's a really important factor that has been partially explored in the report. I actually think ensuring or being even more clear about how the avoidance of diversion and making sure everyone really understands the quality controls is critically important. So it's in there. And so just to close out with a couple of things, as the IPMA, we do talk quite a lot about collaborations and about licensing. We have a report that I have been instructed to demonstrate is on our website, which lays out what we believe makes for a good technology transfer environment. We also held a very interesting meeting. I believe you were there, Anthony, last summer up the road, where we had a set of innovator companies together with the recipients talking about how to make tech transfer work. And that's available on our website. If anyone wants to see that, it was a fascinating discussion. I certainly learned a lot, and I think everyone did. And anyone who's interested in looking at that, do get in touch with us, and we'd be happy to show it. So, in summary, and I'm really looking forward to the final point. Sorry, is that there are two sorts of live examples, I think, of moving a bit broader than historical licensing that are we're all looking at, right? One is the GARD-P agreement with Shionogi on cefiderocol, innovative antibiotic, has very specific requirements and still challenging to actually get that to the right patients at the right time. And the other one is the one that Carrie will talk about in terms of the Atom Coalition, when what's different there is that it does bring the licensing together with all the other parts of the chain that are needed. And so we're very excited about both of those, but we really want to see how they deliver for patients around the world. We want to see the success coming through there. Thanks.
Thanks, James. Dr. Susano, would you like to go next?
Thank you very much. And thanks for the opportunity to be here. IGBA is the International Generic and Biosimilar Association, and we represent the generic and biosimilar medicines industry. Our role is to strengthen the collaboration between the regional and the local associations, and we work to enable innovation and competition to increase access to quality assured medicines. We seek to advance global efforts to improve access to medicines. And for us, important factors are regulatory cooperation, harmonization, robust balanced IP systems, because we think it's important to foster innovation and sustainability of medicines manufacturers so that we can have a sustainable environment to provide medicines to patients who need them. The report highlights, as Sandra so eloquently explained, several business drivers. For us, one of the ones that speaks highest to us is the increase in the patients reached. There's voluntary licenses that have been used in the space of infectious diseases, but there's an untapped potential in NCDs, and having the opportunity to have voluntary licenses that may be one of the tool is an element to the chain that could increase access to patients in low and middle income countries to conditions like diabetes or cancer or cardiovascular diseases, and these all speak to us. Just looking at my immediate family, I have all three cases that I've just cited. And I think it's important that patients throughout the world have access to treatments that exist to treat those conditions. And as a clinical pharmacologist, this is something that's also extremely important to me, to think that there are treatments available, so we should get them in the bodies of patients who can benefit from them. And I think it's important also to mention, Sandra also alluded to this, that NCDs impact 74% of global deaths, or maybe Amy. And I think that this is really a number that we have to reflect on, because if there are solutions that may help treat more of these patients, I think that it's our responsibility to see how we can make them work. Thank you.
Thanks, Susanna. And next, if you can hear from Lizzie.
Thank you, and thanks to MPP and WIPO for inviting me to join the panel here today. It's a pleasure to be here and to talk about this really interesting report, which I think draws out some great findings on how voluntary licensing can benefit global health and still be economically viable for biopharmaceutical companies. Just to start by saying, I think I'd like to emphasise this has been an area of real interest to the UK for some time. Some people may know that in October of 2023, we put in a paper to the TRIPS Council at the WTO on IP, voluntary licensing and technology transfer, which really was aiming to reflect on the successes and shortcomings of the pandemic response, with a view to finding ways to improve the operation of the framework in the future. So it's great to be able to continue building on that and some of that discussion. Before I go too much further, I will just say that for those that don't know, the UK has joined the long list of countries holding elections this year, and our Prime Minister called for a general election which will take place in July. So I am slightly restricted in what I can say. I obviously can't preempt what any future UK government will say. But that being said, I think what I wanted to reflect on a little bit on the key drivers here was that there are 8 great key drivers, and I think they can speak to different stakeholders and to different parts of the process, which is really important. So to kind of echo a little bit what Sandra said, you know, it's all the drivers combined, which is where the impact will really be. I think that's a very interesting reflection. But also to slightly copy Susanna, I think I also picked up on the reach to more patients, which obviously can speak to business opportunities, but clearly speaks to supporting broader and increased coverage of medicines, which is incredibly important and what we want to be seeing. I think it's also interesting to think about the market shaping capabilities of voluntary licensing, and I think we can see from the report and what several previous conversations that have happened on this topic, that working together, having these collaborative partnerships does promote expertise, trust, and can be really beneficial to developing and least developed countries. And just a final point, if I can, I just wanted to draw out an aspect that I took away from the report is that businesses, partners, people don't feel like they have to be doing this voluntary licensing alone. We have mechanisms, MPP, that are an essential part of the puzzle. And I think that they have all the advantages there of being a proven and trusted model, can help to mitigate overheads related to negotiating and structuring new partnerships, and of course, supporting the pooling and sharing of knowledge. Thank you.
Thank you, Lizzie. I think we have a favorite already, which is the increased patient reach, and not surprising at all. Next, we would like to hear from Mr. Marumo.
Many thanks. Like others, I'd like to thank the WIPO and MPP for putting together this excellent piece of work and for the invitation today. Like my distinguished colleague from the UK, my country is also in election season. In fact, our election is today. So, while my compatriots are enjoying a public holiday and exercising their democratic right, I'm here, but I'm very happy to be here. So thank you. First, let me indicate that, like others, the idea of unlocking new patient segments is the one that appealed to me the most. In particular, the idea that non-originator sales do not cannibalize originator sales. As was mentioned by Sandra and my distinguished colleague from the UK, there's complementarity as we see it between the various drivers. In my view, the central theme of the study is how it seeks to highlight that voluntary licensing can serve to the mutual benefit of originators, non-originators, and the public at large. And so, like was mentioned by Director Taubman, this is not a zero-sum game. We believe that voluntary licensing is a strategy that offers mutual benefits for originators as well as generic producers. For originators, voluntary licensing allows them to enter new markets and reach patient segments that would otherwise remain inaccessible due to various barriers such as pricing and the conditions in a particular market. And this expansion can lead to overall sales enhancement, and this can foster long-term sustainable growth. So generic producers, on the other hand, gain the opportunity to manufacture and to distribute high-quality, affordable versions of essential health products. And this collaboration allows them to leverage the research and development efforts of originator companies and to receive tech transfer while contributing to the broader goal of improving health. So this partnership between originators and non-originators results in a symbiotic relationship, ideally, where both parties benefit from the expertise of one another and market expansion. And in turn, this can catalyze local production, which is critical for health security, as we saw in the context of the pandemic. So specifically, if we talk about market expansion rather than cannibalization, we see that the term cannibalization suggests that the non-originator sales would directly displace those from the originator, resulting in a net loss. However, this perspective overlooks the crucial aspect that the market for health technologies is not monolithic. It's segmented with different patient groups having varying abilities to pay and differing access to healthcare systems. So voluntary licensing allows originators to produce and to sell lower cost versions of needed products. Originator companies can cater to different segments of the market. Wealthier patients, those with robust insurance coverage, continue to purchase the originator product, while patients in lower income brackets could gain access to more affordable versions, and this can lead to overall expansion of the market rather than mere redistribution of the existing demand. And if you look at the study, I was drawn in particular to pages 15 and 16 that looked at the example of metformin, and there were very good examples from the introduction of the non-originator product in the Mexican market and the South African market, where I come from, and where the product was unavailable at all due to price prior to the introduction of the non-originator version. So we commend the study and certainly hope that it would be one of the factors that would contribute to increased uptake of voluntary licensing. Thank you.
Thank you so much, Marumo. Thanks for sharing those thoughts. Next, Dr. Carey, over to you.
Good afternoon, everyone, and thank you very much for the invitation to join this panel. And thank you for the report, which I read with great interest. Perhaps before I start, just to give an overview of who we are. So the Union for International Cancer Control is based just down the road, about 2 minutes walk from here. It's an NGO based in Geneva, works with WHO in formal relations, and we have about 1,200 cancer organizations, patient groups, cancer societies around the world who are members of ours in 170 countries. In the middle of our purpose statement, it talks about addressing inequity around the world. And about 3 years ago, we started a campaign on World Cancer Day about closing inequities around the world called Close the Care Gap. And about the same time, Charles Gore and his team approached us and said, we really would like to talk about voluntary licenses for cancer. And that struck a chord with us immediately, because in low and middle income countries, the availability of even the essential medicines list for cancer And certainly some of the more popular ones in Europe and North America are simply not available. And this seems to be unfair. Particularly medicines that are 20, 30 years old, they should be available in those countries. Now, there's a whole series of complications about cancer medicines going into LMICs, and I'll talk about those in a moment. But with that approach from MPP, we decided that medicines, particularly cancer medicines, going to LMICs is not a question of just getting a voluntary license, identifying a generic or biosimilar manufacturer, and taking them to that country. Because there are so many challenges and there are so many blockages stopping that medicine when it arrives actually getting to the right patient at the right time, and not least being pathology, diagnostics, the human resources, the availability of oncologists, radiologists, radio-oncologists. There's so many things that need to be put in place. So the solution that we came up with was to pull together a partnership of organizations with a similar common ambition to address that large gap in availability of medicines in LMICs. And we were lucky enough 2 years ago to launch that coalition. And it's not UICC and MPP and a couple of others. It actually stands today, I think, at 45 organizations, companies and NGOs, international NGOs, specialists in pathology, specialists in clinical medical oncology, direct relief, Project ECHO, I can go on and on and on. And to be honest, it demands that sort of attention. So the voluntary license model, which kickstarted that coalition, and it was the catalyst for that coalition, has actually concluded this so far after 2 years, not just with solutions from voluntary licensing through MPP, but also through the delivery of a platform through the IDA Foundation, which now delivers 70 cancer medicines to LMICs, which weren't available a year ago, and 15 diagnostics, which weren't available a year ago. So we're making progress in addressing that inequity issue. But voluntary licenses are absolutely critical, because in the longer term, we would like to feel that a company that produces a blockbuster medicine has the confidence in the system, the coalition around cancer and the MPP model to release that medicine into those markets more quickly than they do today. It will be ideal within 2 to 3 years, maybe, because of the power of social media and the internet. When that release goes out there, everyone knows about that medicine. And if you've got a child in an LMIC and you know there's a medicine that could save that child's life, you don't want to wait 20 years. You don't want to wait 20 months. So we see the voluntary license model as being absolutely critical to the overall solution of addressing the availability of medicines into LMICs. Now, with the report, if I can just comment on the report, I too also love the idea that we're making medicines available to a broader patient group. Whatever that number is, 4 times, 5 times, 10 times, I don't mind. It's important that we can reach those patients with the medicines and the technology that we have at hand today in Switzerland, for example. However, I must say that I went through a bit of a change curve with the numbers. And I also had to read some of the graphs 3 or 4 times. I don't know if I was the only one. It took some time to understand the graphs. But I was a little bit worried about the potential revenue increase of only 3% on the cancer meds. But having thought it through and looking at the revenue generated by cancer meds for the currently patented medicines, which runs to tens of billions, I realized that 3% of a very big number is a very big number. And actually that very big number, whether it's hundreds of millions or billions, could easily, in my opinion, be redeployed to address the core competencies required to receive those medicines and then to use them. Pathology labs, diagnostics, training of nurses, training of oncologists, dealing with the procurement challenges, the ability to register. If we were able to do that in parallel with the VL benefits of revenue income, then we do create, in the terminology of the private sector, and I used to be in the private sector, markets of the future, because the core infrastructure is there. So I think, yes, there are 8 drivers, but they are linked, and they could be linked successfully. I would like to say that working with MPP, we're delighted that we do have now a voluntary license going through with nilotinib from Novartis. I'd like to thank Novartis for being the first to go ahead. I am hopeful that other companies will follow that lead, because the Atom Coalition is there, ready to work on the ground and with all partners to ensure that the benefit of that medicine is received by the patients who need it at the time that they need it. So I think the report is great. Congratulations to everyone. I hope it starts a good conversation about the value we can bring to patients, the value we can bring to companies, and the value we can bring to society. So thank you very much.
Thanks so much, Kerry, for sharing your thoughts. And we would like to turn to Mr. Takanori, who is online to share his favorite driver.
Okay. So good morning, good afternoon, good evening from Tokyo. So I am Takasato from Japanese Pharmaceutical Manufacturers Association, and I'm working on the global health agenda, engaging in JPMA, and also engaging in IFPMA, and also promoting public-private partnership, including GHIT Fund or Access Accelerated. And from my perspective, first of all, it is truly an honor to be here today at the round table, and thank you for giving me the opportunity to be on the advisory board for this initiative. And before going to the driver, so actually the framework of MPP itself is an excellent framework to improve access to medicine, I believe. And the driver that resonates with me most in this report is the impact of voluntary license on the improvement of access to medicine and health equity. This driver is compelling because it addresses a critical global health challenge, ensuring equitable access to life-saving treatment. It also aligned with the broader goal of global health equity and universal health coverage, which are central to many international health agendas. Furthermore, it presents a win-win scenario where originator company can generate additional revenue stream while contributing global health improvement. The impact of voluntary license on patient access is not only an ethical importance, but also a strategic business decision that can enhance a company's reputation, fulfill also strategic business fulfill corporate social responsibility, and potentially lead to more sustainable business model in the long term. In summary, drivers of improving access to medicine through voluntary license resonates due to its ethical significance, alignment with global health objectives, and potential for positive business outcomes. Thank you.
Thank you so much, Taka. Thanks to the panelists. We've had some really interesting thoughts from all of you. Thanks for sharing that. And we would like to delve more into each one of your comments in the second set of questions, for which I hand over to Siddharth.
Thank you. So our next question is to James Anderson from IFPMA. So IFPMA as an organization is a strategic bridge between the innovative pharmaceutical industry and other stakeholders in global health community. So how can we leverage the findings from the study to encourage the pharmaceutical industry to consider voluntary licensing models as a potential mechanism to expand access to essential medicines?
Thanks, Siddharth. So building on what I said first time around, but also what others have said, I want to just pick into a couple of the more specifics that are in the report that we think are very helpful to encourage the discussions that are needed. So the first one is just recognizing that the licensing process actually does work quite efficiently today. It can probably be improved. We saw during COVID that still the overall process actually took longer than probably is ideal during a pandemic where time is of the essence. But what we also saw was the importance, particularly during the transfer of technology phase, of why we emphasize the need to make sure that all these agreements are done voluntarily and very much on mutually agreed terms, because what we heard in the meeting I referred to was the challenges of making the technology transfer work, in particular at high speed, but even under normal circumstances already. So that's recognized in the report, and we believe that's really important and actually helps open up the discussions that are needed. That's the first one. The second one then is I think having more discussion like this in order to explore and unpack all of the rationale here. There's a lot of different reasons. different companies, as I said up front, will have a different approach to thinking about how they do access. Many companies have partnerships already with generics companies or others around the world, and will do bilateral agreements, and that's one way to do it. I mentioned the GARD-P agreement. That's actually done via CHAI, right? That's fine. That's 135 countries in one go. And then many companies talk and work with the MPP as well. So from our perspective, also in the report, it's really important that, you know, all options are good, right, as long as they move forward. And then the final thing, which also is in there, but I feel is sometimes underplayed a little bit, is what Carrie was talking about, which is that you've got a long chain of things that need to happen in order to get the medicines from a company to a patient. And if any steps along those chain don't happen, it doesn't get there, right? So licensing is one step, we would argue. Trying to think and work together, and Sandra, you emphasize this in your opening remarks as well, that to do anything we can that joins up the chain, makes sure there aren't any other gaps. That's a big undertaking. And actually, I think this came through from your points as well, Anthony. But that's something we also believe is critical for success, and something that we all, as the global health community, need to play a role in.
Thanks, James. Next question is to Susanna. So participation from the generic pharmaceuticals is one of the key pillars of success for voluntary licensing. How can voluntary licensing contribute to the goal of universal health coverage, and what role can generic and biosimilar companies play in achieving this goal?
Thank you very much. We've heard the example of how the voluntary licenses played a role during the COVID pandemic, and there were agreements between the originators and generic companies that allowed to get treatment to patients. For example, I'm looking at my notes. Pfizer's and Merck's antivirals were produced by generic companies to expand access in low and middle income countries. How this can work to contribute to universal health coverage? Well, by allowing generic and biosimilar companies to produce licensed versions of medicines, the costs can be reduced and the treatments can become more affordable. Voluntary licenses, as we've discussed here today, expand access to essential drugs and bridge gaps in healthcare systems. And universal health coverage ensures equitable access irrespective of where people are. And voluntary license supports this by reaching those underserved populations. What we can do as generic and biosimilar companies, we can produce the licensed medicines, increasing their availability. We can establish working partnerships with originators and governments that can strengthen the healthcare systems. But one point I'd like to highlight is for generic companies, generic and biosimilar companies to engage in the voluntary licensing. It's very important that regulatory efficiency needs to be enhanced dramatically, and that we have market predictability to go along with these needs. So as I think James was also alluding to, the license is one part of this, and it's one of the tools, but there are other tools that are needed to make sure that this reaches as many patients as possible. It alone will not solve the issue with patient access because of its current limited scope. So I think the scope is another important aspect of this. For us as generic companies, evergreening is another challenge that has impact on access. And we believed in a balanced intellectual property system as a way to enhance and expand universal health coverage. We can play a role directly as an association by ensuring that when new licenses are available, this information reaches our manufacturers through our various different channels, and including in the Global South, which I think is an important angle to this. And we can get this information along to the companies who will help materialize these licenses.
Thank you, Susanna. Our next question goes to Mr. Takanori. So JPMA was one of the members of the advisory board as well. And Japan is also home to many innovative companies and also has MPP license with Shionogi for their COVID-19 molecule. So the question to you is, in the context of the Japanese health ecosystem, what are some of the challenges in using voluntary licensing? How can these be overcome? And what role do you see JPMA playing?
Okay, so from my personal observations, I want to share 5 major challenges for Japanese company to use MPP. So first one is the cultural and business practices. So Japanese companies often have unique business cultures that emphasize consensus building and long-term relationships. Engaging in voluntary license through MPP may require a shift in mindset and internal corporate alignment, which could be challenging in a culture that values careful consideration and consistency. And the second one is intellectual property strategies. Japanese pharmaceutical company, like many others, invest heavily in R&D, may have stringent IP protection strategies. There may be concerns about sharing proprietary information and the potential impact on their competitive advantage, which could make them hesitant to engage in patent pooling. And the third one is a market focus. Japanese pharmaceutical companies may have a strong focus on developed markets with established regulatory and commercial infrastructures. Engaging with MPP requires a commitment to expanding access to medicine in low middle income countries, which may not align with the current strategic market focus of some Japanese pharma companies. Fourth one is the regulatory environment. The regulatory environment in Japan is known for its stringent standards and processes. Company may perceive challenges in ensuring that licensed generic manufacturer meet these high standards and may have concerns about maintaining quality control over their products. And the fifth one and the last one is internal expertise. Engaging in voluntary licensing requires specific knowledge and expertise in global health, access strategy, and international regulatory landscapes. Japanese company may need to invest in building or acquiring this expertise to effectively engage with MPP. In summary, to address these issues, Japanese pharma companies would benefit from a thorough understanding of MPP model and its potential benefit and support systems in place to mitigate risks. Engaging with stakeholders, including patient advocacy groups, global health organizations, and industry peers who have successfully partnered with MPP can provide valuable insights and help overcome hesitations. Additionally, aligning voluntary license efforts with CSR or ESG can create a compelling case for participation in the MPP. Thank you.
Thanks, Taka. So we'll move on to our remaining panel in the room. And the next question is for Lizzie. We spoke already a little bit about non-communicable diseases. A lot has been done in infectious diseases through MPP licenses, but NCDs is our first area. And as I think Susanna quoted, that more than 70% of deaths globally have been because of NCDs, and a bulk of that has been in lower and middle income countries. So the question is that what actions can governments take to support the wider adoption of voluntary licenses to tackle the problem of NCDs?
Thank you. Well, I think it's, Marimo can hopefully support me on this in saying that it's fair to say that the topic of voluntary licensing is very much a live topic in Geneva at the moment. I think there's real interest in looking at it, and certainly the UK was really pleased that we were able to be part of I suppose, a bit of a kickstart of a discussion around how voluntary licensing can help support access to medicines with our paper that we put in. And again, Marimo is also part of putting some interesting papers into that discussion as well. So I think what's interesting, what's helpful for governments is that we can help be part of driving some of that conversation. We've heard quite a lot already, I think, here today about how voluntary licensing is complex. It involves lots of different parties. James spoke about there being a chain. It's not simple, and I think governments can look at how we draw together perhaps all of those elements and bring them together to ensure that holistic view, which is going to be critical for ensuring that voluntary licensing is successful. It is one part of a chain. We need to look at all the other elements that are involved as well. I think it's also important to underline that for the UK, an essential foundational element is for governments to put in place effective and balanced IP systems. Again, we've had, I think, several times today, the importance of balanced, robust IP systems. And these really do underpin relationships that are based upon trust. They can help mitigate fears, perhaps around voluntary licensing. And I think it's fair to say that having a base of legal certainty and environment that can foster collaborative innovation is really, really important in this conversation. I think I would say, the UK doesn't hold all the answers. No one government does. I think we'd all like to be able to say that we do, but that isn't the case. But we are, as a government, very open to hearing ideas about what other levers there are to influence and promote voluntary licensing, particularly that are available to governments, and thinking about how we can make the most of those. And really hope that this report, this study, these kinds of conversations can be a foundation on which we build to really think about how we can have better adoption of voluntary licensing, how we can really roll it out so it works for across different medical products, medical technologies, be it addressing communicable diseases or non-communicable diseases. Thank you.
Thanks, Lizzie. Continuing on the thought of NCDs, we'll have the next question for UICC. Thanks for talking about UICC and the ATOM coalition, Kerry, at the beginning, and the fact that, yes, MPP has the license for nilotinib, the very first of its kind in the NCD space. And as James also pointed out, we are talking about an access chain and every stakeholder is important, but it is established that voluntary licensing alone is not sufficient to bring or to ensure patient access for everyone. So the question, Kerry, is could you share your perspectives on the benefits of adopting VL model for the NCD space and the collective action that is required today across public, private, and civil society players?
Sure. I think we've heard some numbers already about NCDs being 75% of deaths globally. If I focus on cancer, the numbers are not dissimilar. 75% of cancer cases, cancer deaths occur in low middle income countries. And in the next 20 to 30 years, 75% of the growth will be in low middle income countries. So as a generation, if you drew a picture of the world and said, where do we need to put our resources in order to save the maximum number of lives in the future? We've got them in completely the wrong place. So as that growth in NCDs and cancer occurs in LMICs, I think we need to reflect on the ways in which we can create the environment through which the innovations that we've already had over the last 10, 20 years and in the future can be made available in the parts of the world that desperately need them. I've heard the word, it's complex and complicated and things like that. And I struggle to understand that because my iPhone is really complicated and complex, but it seems to be getting everyone's hand around the world and works perfectly with every app that man's made. So I would temper our concern about complex and complicated. I think that we need to reflect on how we're going to solve the problem as we have done in everything that we do. My colleagues from Roche and others, you have fantastic innovative processes. And if it wasn't for you, we wouldn't have the drug set we have today to address the NCDs. And if it wasn't for you, we wouldn't be able to address the cancers that we have in the future. Innovation is inbuilt in the way that we are delivering and developing the solutions to treat NCDs and cancer. If we can deploy the same attitude, approach, innovative skills, and bring the resources together, we can crack this nut. And not just crack it through a program or a project in 2 or 3 countries. We can crack it in a sustainable, systemic way so that we can give hope to future generations that if they do get a cancer, they have a reasonable chance of it being treated. Now, that does demand different players being together, without any doubt. And I would put at the center of that the governments of countries which have this growing burden of NCDs and cancer occurring within their population as they move beyond the communicable diseases. So I think it needs to be a whole of society approach. The VL itself is critical because that's a safe, secure, quality way of transferring the capability to treat into those countries that really couldn't afford the pricing of drugs that are in America and Europe. But I do believe that governments also need to play a role. The final point is we tend to come across the same barriers in cancer, whether we do VL or we do generic or biosimilars. There's some common barriers which ignore country boundaries. And the common barriers are pathology and diagnostics. Okay, unless we ramp up pathology and diagnostics for cancer right across all LMICs, then we are not going to be able to get medicines to the right people. And that's a common challenge. It's a challenge for governments, for patients, for NGOs, civil society, for companies. It's a common problem. And I do wonder whether as part of this report and everything else that we are able to reflect on where we can collectively address those common problems. And if we can collectively address those problems, then that makes it easier for future VL discussions. And that would be my ambition, that today's breakthrough with working with Novartis, that should be considered a breakthrough in the first instance. I'd like to feel in 10 years' time, there are 6, 7, 8, 9, 10 voluntary licenses flowing through the MPP system and being received by patients and saving their lives. That would be my request.
Thanks, Gary. Our last question is for Marumo. So recently, MPP and we've celebrated the 10-year anniversary of dolutegravir, where it was, I think, more than 1 billion packs of MPP licensed dolutegravir reached patients. South Africa is the largest procurer of the licensed dolutegravir, and it could not have been possible without the role played by governments. So the question is, Marumo, that once a VL has been signed, what concrete actions can governments take to promote faster uptake of those licensed medicines?
Thanks so much for the question. Very difficult to take the floor after Dr. Kerry. I think I'd like to perhaps start by agreeing with Dr. Almeida. when she made reference to some of the challenges presented by evergreening and the need for balanced IP system. But another pointed area is one that I discussed with my capital-based colleague from health before she went on public holiday. And that is that we have a significant challenge of ensuring that the manufacturers to whom the voluntary license is awarded comply with the domestic regulatory processes, and also ensuring that the process for the issuance and awarding of the tender can accommodate this. Now, one example is cabotegravir. Many of you will know better than me that in fact it's potentially game-changing injectable pre-exposure prophylactic. Participants in the clinical trial that was held in South Africa provided feedback that leads our health authorities to believe that it could be significantly excellent in terms of adherence. So in our context, we have 3 non-originators that have received voluntary licenses to manufacture the product. And in fact, thanks to MPP. We also believe that the 3 manufacturers having been awarded is very good in that it would promote competition and reduce price and result in greater affordability. The product was registered timelessly by the South African, in the South African Health Product Regulatory Authority. Many of you will know that SAPRA was awarded ML3 status by the WHO. However, what I'm informed by health is that the 3 producers are yet to complete the necessary licensing processes and that there's a tech transfer underway. So what we need to ensure is that going forward, the tender process, as I indicated, would be flexible enough to accommodate all of these moving parts, and that would help us to ensure speedy uptake. Thanks.
Thanks, Marumo. Well, thank you, all the panelists. This was quite an interesting discussion, and we learned a lot. And Siddharth, should we take questions?
Yeah. Just a quick note, for those of you who are here in the room, Siddhartha will be facilitating the Q&A session. We have 15 minutes. For those of you who have joined us online, Esteban will be keeping an eye on the questions that come through in the Q&A block, and he will be reading out the ones 50. Oh, and there's a queue of 51. So Esteban, you have your read really quickly. But we do have a full 15 minutes for this, which is great. And for the online questions that we're not able to deal with today, rest assured that the team will come back to you in writing in the weeks to follow. So Siddhartha and Esteban.
Thank you, Amy. So questions from the floor.
So clear. Go ahead and take them this one.
Yes, please go ahead.
Yeah, but I am the least qualified person in the room, so I feel very embarrassed to be the first one to ask a question.
Please go ahead.
I am a journalist, and it may sound ironical that I play the devil's advocate and sound pro-business, but there are reasons thereof. Since I became a journalist, most of you were not born yet, on even days I heard praise the genius of the inventor, the bioscience researcher, and he should even launch his startup because he's a savior of mankind and he deserves just a few billions in reward because his startup will be at the stock exchange, but it's very little to the benefits he brings to mankind. And on odd days, I hear just the reverse, that is that pharma industry, that disgusting how much money they made, and now they have to give it back to the public. So, of course, me, who has no scientific qualification, no business qualification, that's why since I know nothing, I became a journalist, I feel a little bit disturbed by this permanent change of rhetorics, narrative, and evidences which sound very political according to where the wind blows. So now I ask the whole audience, who among you knows what is the part of medicine that is a drugs in the health budget? I know each time I check, I forget, but as far as I remember, although it's different in rich and poor countries, it is very marginal as compared to other sorts of expenses. So why only, you see, the logic of the civil society and even WHO is the losses for the pharma and the income for the medical corps. I have never heard a single critique against the medical corps from WHO. So this is why I perceive all what I heard today as very interesting, but very circumstantial and very politically oriented. I also heard yesterday something less politically oriented, that 1/3 of medical acts are useless or counterproductive. We all know that, but this is also a topic which is more or less taboo, etc. So I sacrifice myself to be the villain, and at least since I am the villain, I could say a few things which good people, good guys cannot.
Thank you for your question. We take some more questions from the floor.
Thank you. Can you hear me? So my question is about early on in the process, so long before somebody's thinking about licensing, from that perspective, thinking about the funding that goes from governments into academic institutions and other early stage research institutions, and whether the panelists feel it would benefit voluntary licensing uptake to include terms around equitable access and a requirement to do this sort of licensing from those very, very early stage licenses that come out of university. So if a university, just to be clear, requires their licensee to do subsequent voluntary licensing, whether that would assist. Thank you.
Hi, my name is Joanna Morrison-Derb. I'm from the NCD Alliance. We're also in official relations with the WHO. I'm interested, it's absolutely great to hear NCDs mentioned so many times, and there is the UN high-level meeting, which is coming up in 2025. So I was interested what opportunities the panel feels there might be for voluntary licensing and the whole access to medicines chain in this forum. Thank you.
Maybe we'll invite the panel to respond.
Go ahead, Gary.
Yeah, okay. Let me respond to the ones I want to respond to. Is that okay? And I'll leave the others to respond to the ones that I don't respond to. Okay. Over to you, James. All right. When does access come into the development of a new medicine? And I'm talking about cancer. I actually was at a lunchtime meeting, and I asked that question. I don't know who else was around the table at the time. I asked the question, at what point during the product life cycle does the company start thinking about how they're going to make that medicine? Should it get through 1, 2, and 3 of trialing? When do they start planning the execution of a desire to make it available in LMICs? And the answer I was given was that it's at the second stage of trialing. Was that second? I don't know who was there. The second stage of trialing. I did find that a little bit surprising, because from an outsider's perspective, it does feel that the thought about making a medicine available outside the large profitable markets is a after discussion, and And it isn't built in at the beginning. Now, whether that's really, I wasn't talking about universities or startup, brilliant companies that find a new molecule, whatever it was. I was quite surprised, but I do feel that there is a need for maybe companies to be a bit more open about at what point they start thinking about how they made that medicine available beyond the normal target markets in order to give assurances of access in the future. Now, whether that be through a VL or the pricing, or whether it be through an alternative method, I'm not sure. But I think that there is mileage in the conversation about when do you build in the thought about inequity and access. I certainly, from the people I talk to in the sort of site environment, get a sense that it can almost look like an afterthought and under pressure. Rather than being built into the product's life cycle. I'm happy for any of the companies to step forward tomorrow, anyone else, and say that's not quite how it is. But I'm just saying about perception, it's not quite, it wasn't, I didn't feel it was early in the process.
Thanks. Just to kind of follow on a little bit there, I think that's it's a really interesting point that what is important here, and I think from this report, we've seen that there are huge benefits to voluntary licensing. It's not, as Tony said, it's not a zero-sum game. This is a win-win. This helps industry, it helps businesses, it will also help patients. And so the more that we can bring air to this conversation and bring that out and ensure that people realise that, and that becomes the sort of the norm, the understood message. I think that's really important, because if we can integrate that thinking around equity of access throughout the process, throughout these the system, it will help. And whether it's about putting in terms early on in the research process, or doing that later, I think it's about having the conversation so that people are so conscious and aware of how we can support equity of access in the broadest sense, and it will be all parts of the piece that will help to do that. Thank you.
Let me talk to a couple of the questions. So Emma's one about linking a requirement for a licensing to any part of the development program. That will have the tendency to discourage companies from doing that research, right? That's the bottom line. And so what we seek is more the unlocking of the pathway that I talked about before. Because that's the opposite, right? So that says, as you develop a medicine or vaccine, do be proactively planning it, which companies do, as Carrie said. But let's build a pathway that makes it easier rather than harder. At the moment, it's really hard for anyone, whether it's a generic company, whether it's GARD-P, whether it's anyone to go down that path. So what we should be focused on, and I really see it as I said before, really as a collective effort of this community around this table and around in this city right now, is to make that pathway as easy as we can and to unblock the blocks. So much better, but that's our preferred approach to it by far. Just to briefly touch on a couple of the questions that you raised, the wastage point is clearly bad for everyone. Companies are, when they develop a medicine, absolutely try to prove that its benefits and have to demonstrate the benefits to get through the regulatory process. But at the same time, the medicines don't work the same way for every individual. So there's a lot of work that then goes to try to identify those patients that a medicine won't work in, to try and avoid the wastage. We're not there yet, but again, I think that's a collective effort to reduce wastage. That's a really aligned goal across the system. And you're right, the 10% of spend on medicines out of a total healthcare system is somewhere usually around 10 to 20%. So it is the minority. And again, how the industry thinks about that is we we try to develop products that actually take cost out of the rest of the system, right? So a good example is a medicine that avoids the progression of a disease, particularly a chronic disease, which means if you can maintain a patient at a certain level, particularly when they're caught earlier, it can be much easier to manage them rather than waiting until they have a bigger problem if it's, you know, if it deteriorates. So just to touch on a couple of the points the gentleman behind me raised.
To Esteban. Thank you very much, Siddhartha. And perhaps what I'll do is just, I mean, there have been a lot of questions online. I've been trying to answer some of them live on the platform, but just to give a flavor to people here of the kinds of questions that have been coming in, and maybe I'll then take the opportunity to raise one of the questions that's come into the Tuna panel, if that's okay. So in terms of the kinds of questions that we received, one of them was around yes, fine to get the license, fine to get the generics developed, but then there's a lot of delays around the regulatory processes and you know what can be done about that. So something, you know, comes to the point about, yes, all these other challenges that we need to, of course, address when we're thinking about access. There've been questions around whether we had licenses on malaria products or rare diseases. I've clarified that online at the moment, not really, except an early stage technology for malaria, but otherwise not. So it might be interesting also for the panel to reflect on whether this kind of approaches could work in rare diseases, for example. How can voluntary licensing actually result in greater affordability? And so there, I think we have some good examples, particularly in HIV. So I've pasted some of the papers on that on the chat. Yesterday, in fact, we were celebrating 10 years of our license on dolutegravir with ViiV Healthcare, which is a license that has enabled today to have the lowest WHO preferred HIV regimen that we've ever had at around under $45 per patient per year, and 24 million people getting access to that regimen today. So of course that is the result not just of the license, clearly, of all the other things that have happened. And of course, I'd like to recognize the communities that have played a significant role in shaping that response, and Unitate, who has played a critical role in across the whole story. We've been asked about questions about licensing from universities as well have come up, so are similar to the question that was made here online about access to the report. And perhaps I'll take the opportunity, if I may, Siddhartha, just to raise one question which I wasn't able to answer, and so I thought I'd, crowdsource and look for what you might be able to contribute. So the question comes from Michael Mbogoro, excuse me. One of the concerns raised by originators is that the infrastructure, judicial systems, and business environment in many LMICs often complicate the ease with which they can do business in these regions. How is the work carried out here, which is remarkable, complemented by initiatives to improve adoption, ease of doing business, and infringement issues? It's quite a broad set of issues that are raised there. I may be able to answer some of those, but many are way beyond my understanding, so I thought I'd bring it to the broader audience. Thank you.
So now I'm taking notes from those who have more experience in World Health Assembly Week than myself. So what I'll do as Carrie just did before, and I'll pick one of the questions. The one about the regulatory aspects that come after the agreements have been reached, and now let's implement this. This is something that IGBA has very firm opinions on. Harmonization and convergence in the regulatory space are critical. I take this very seriously personally because I have been an expert with various ICH working groups, International Council for Harmonization, for 10 years. And this is an area that is really playing a critical critical role in the process of getting the medicines to the patients. We need to, in as much as possible, move away from the domestic requirements into a space of harmonized requirements. And ideally, from a generic standpoint, the process of having the possibility to have single global development, that's one data package that's equally acceptable in the various different regions, is paramount. This is the process that the originators always use for their development. It's not a reality in most regions for generics, and this is an area that we are very interested in seeing developed. Of course, WHO is working hard to develop their reliance procedures with the SRA CRP that is increasingly possible in more countries. But I think that we cannot underestimate the importance of that angle for the access. So.
Can I just jump in, because we need to work together on this. 100% agree. We have a lot of active work on that, because it would make a huge difference, no question. The other one I wanted to pick up on, Esteban, to your sort of set of questions there, was to refer to a really interesting discussion on earlier in the week, Monday, I think, that Lilly hosted, where they've out-licensed the production of insulin to a company in Africa. And they were talking about two things. First of all, how that transfer is going. And secondly, what is needed by the African company, Ava Pharma, to be sustainable. And they were talking about a lot of those challenges that they are now having to work through as an African company, being a local manufacturer that is so called for, and yet still all those challenges are very real, and a really fascinating discussion. If anyone's able to view that one online as well, I would thoroughly recommend it.
Esteban, yes, I see your placard is up. Normally I wouldn't allow it, but
Because it's you.
because it's you.
Sorry for that. No, just there was just one other question I forgot to mention that I thought was an interesting one that perhaps we don't need to really answer it, but one of the questions that came in actually was proposing a potential ninth driver. So I thought it'd be interesting perhaps to bring it here. And I'm looking for it. Of course, I'm not going to be able to find it right now under the the 56 questions that have come in. But it was essentially, the question was essentially around the grant back provisions that appear in MPP license, as licenses are increasingly sophisticated, increasingly have R&D capacity, are improving processes for manufacturing, are often further innovating on the basis of the license that they receive. And then there are provisions within the license that grant back those technological improvements on a non-exclusive basis to the innovator, whether that potentially should be considered as a ninth drive. I'll leave that there. I don't know if there's an answer for.
We had it, we just couldn't quantify it.
Right. I'd like to thank the panel for such a rich discussion and for fielding some very challenging questions. And I will hand over to Sandra, who will conclude in 30 seconds.
Who knows me knows that talking 30 seconds is just impossible. Thank you all. Thank you, the convenient. Thank you, the funders. Thank you, the panel. Thank you all around this. And I quote Kerry here, let's crack this nut together. Okay. See you. Thanks, everybody.